Our next speaker is Dr. Copeland, and he's going to be talking about management of intrinsic brain tumors. While he's setting up, does someone have any other question for Dr. Bale? One question.
Mine is a comment rather than a question. Some of us have taken upon ourselves not to think of a resource-constrained setting. Now, what's from the previous speakers, most of what is important is to recognize recognition of the injury, recognition of what you need to do. So, if we become more of advocates, we become medical politicians, neurological advocates, so that this message goes to the people who are from level 1, level 2, from the point of contact of a patient with a head injury. In the proper mechanisms for care are instituted from there, you're likely to have a better outcome. So we think that yes, machinery, we may not have that in many hospitals, but the care process, if we start the care process early enough, you have a better outcome than if you wait to refer such a patient to a center that has that kind of a care that may take longer and lose the patient on the way.
All right, can you hear me? Sounds like it's working. So my name is Will Copeland, coming from Tinwick Hospital in Bomet, Kenya. And I have the privilege of talking to you in 20 minutes about how to manage brain tumors. So we are going to do this in a quite... Okay. This is the 2016 WHO classification of brain tumors. So as you can see, we're not going to get through this in 20 minutes, okay? So I'm going to select some of the high-yield tumors that I see most commonly at Tinwick, and I suspect it's the same demographics more or less everywhere. I want this to be interactive, okay? So I really need your help. Raise your hand if you're a trainee or a resident or a medical student, medical officer, just so I can know who to pick on.
Raise them high.
Oh, come on, there's more than 3 of you, right? All right, I'm counting on you to speak up, okay? So, somebody tell me what you think this is. And these are not trick questions, okay? I mean, these are run-of-the-mill photos, so don't hesitate. Yes, sir. I don't think so. And the reason I would say, well, one reason anyways, is, one reason would be, you see the CSF density here? It's not the same as here. Now I can understand how maybe you would see with the T2 signal itself, but that would certainly not be my first thought. Yeah, Khalid. Yeah, I think that's more likely what I would first think of.
They didn't hear the back.
So he said a low-grade glioma. Actually, I don't know if he said low-grade. Maybe I said that for you. So this is a T1 sequence, right? And so you get a hypo-intense subcortical lesion. Here it's hyper-intense on T2, and this is a contrasted image, right? You see the contrast in the sinuses. And it doesn't enhance, which would tend to indicate a lower-grade tumor, okay? What if I showed you this one? Not a trick question, just shout it out. So this is calcification, not blood. What did you say? Lydia? Yeah, that would be my thought anyways, and of course all of this is speculation to a degree, but it looks also like a lower grade tumor. And the reason why you might suspect an oligodendroglioma is it's more cortically based, there's calcification within it. You might have to convince yourself, but maybe there's a little speckled enhancement, which is not uncommon with oligodendrogliomas. Okay, so let me do this. If you got an MRI scan or a CT scan like this and your suspicion is a low-grade glioma, what are you going to do? How are you going to manage this patient? Say they present with seizures.
We first monitor the seizure and the blood radiation.
Okay, sure, all right. So you take the tumor out and it's a low-grade glioma. Now what are you going to do? What's this patient need? Let's say you get a complete resection.
Send to pathology and complete the radiation for this case.
Complete what?
Radiation.
Okay, all right. So this is all very nuanced, of course, okay? And you understand I'm cramming this in 20 minutes, but according to the 2016 update, a lot of the classification of tumors is now done with molecular genetics, not just histopathology. And so, as you said, after your resection, ideally, and in Nairobi they're doing this anyways, you can get molecular analysis. And the two things you would want to pay attention to, particularly with gliomas, is the IDH mutant status and the 1p19q co-deletion status. Okay? And then depending on your degree of resection and a variety of risk factors, if you look down here, it may be small for you in the back, but say you got an older patient, that's a higher risk factor for a worse prognosis. If they're astrocytoma, or they lack that 1p19q co-deletion, that's a higher risk. Or if they're an IDH wild type status. Okay, those are three good, poor risk qualifications to look at. So this is again just a simple algorithm, but if you get a gross total resection and you have no high risk factors, I think many people would say observations are reasonable management pattern here, and I think that's okay too. As you said, if you get a complete resection but you've got high risk factors, most folks would do radiation, and in addition to radiation now, the majority of folks give chemotherapy. It's a PCB treatment. What is that? Lomustine and vincristine, and I forget the P, but someone else can, actually Dr. Anoop can remind us that next lecture. And then of course if you get a subtotal resection, many people would proceed on radiation chemotherapy. Does that sort of make sense for low-grade gliomas? Am I saying anything that anybody really disagrees with? All right. What is this? Same scenario presents with seizures. It's a terrible picture. I'm sorry. What did you say?
My residence.
Yeah. Yeah, sure. Most likely. Okay. What do you want to do for him?
Starting on corticosteroid, dexamethasone, and plant for surgery.
Okay.
Yeah.
So you take the tumor out. Now what are you going to do?
Histology.
So it's a glioblastoma, and I'll leave the MGMT methylation status vague. I don't know. It doesn't matter.
And we counsel the patient, follow the prognosis, and the oncology, radiation. Yeah, and the prognosis is bad.
Yeah, so this is someone, after surgery, you're not going to observe like you might a low-grade glioma, right? And an MGMT methylation status, if it's positive, it's a favorable prognosis, but it's not going to change your treatment so much. Most of these are going to get radiation chemotherapy. Everybody with me? All right, I know I'm telling you stuff you know, but we said this, all right. And that's the street protocol. Avastin is something that you sometimes hear about. Bevacizumab, and that's most commonly used for recurrence. Of course, when you're evaluating for recurrence, right, you got to keep the possibility of pseudo-progression. So if you see an increase in enhancement within, say, 3 to 6 months or so of treatment, before you go rushing back to surgery or something like that, you may at least want to consider the possibility of pseudo-progression. And I'm not going to talk about different imaging modalities and whatnot to look at that. What is this? Oh, come on. Everybody knows what this is, right? Just shout it out. It's a meningioma, okay? Lydia, what do you want to do for this patient?
them if they have seizures, control their seizures, give them a steroid, achieve symptom 1 resection if possible.
Okay, good. At least at Tenwick, I never see this, but maybe you guys do in Nairobi or Eldoret. Say you've got a sub-centimeter convexity meningioma and the patient presented with headache. What might you do, at least in more Western settings? Are you going to rush that patient to surgery? Probably not. For pre-op embolization for a small tumor, no. Well, so how are you going to manage the patient? Are you going to operate? They're asymptomatic, let's say. So observation is certainly reasonable in that scenario, I would say. And at least in the U.S. and in Europe, a lot of people, certainly if on serial imaging the tumor is growing, would do stereotactic radiosurgery. Okay. Now, not only do we not have that capability around here, but I don't recall once seeing a small asymptomatic tumor come into my clinic or the hospital. They're all big tumors like this, as I think you all are well aware of. So, Lydia, you said you're going to take it out, okay? And you mentioned the Simpson grade resection, and we won't go through that. But the idea is that you want to achieve the maximum safe resection you can, right? So the majority of meningiomas are going to be grade 1 tumors or benign tumors. Let's say you get a pretty good resection, Lydia. You get a grade 1 resection. What are you going to do now? Okay, your buddy next to you says, hey, I think they need radiation. What do you think? Okay, yeah, I think
Microphone? Can't be heard.
If it's a grade 1, I wouldn't check it.
yeah, okay, good. Now, about 10% of cases can be grade 2 and about 5% are grade 3. Grade 2 being anaplastic, grade 3 malignant. For those patients, what do you want to do? Let's say you get a gross total resection on a grade 2 meningioma. This is a little controversial, I would say. What do you think? You're regretting ever speaking up now, aren't you?
If it's a grade 2, it's not very definitive radiation would offer any superior benefit.
So what if you get a subtotal resection?
You would radiate, but there isn't much additional benefit in it.
I think most people would radiate a subtotally resected anaplastic meningioma. For a gross total resection, I think folks would do different things. I tend to want to radiate those. Of course, here many people just can't afford it, even if they have access. But certainly for a subtotally resected grade 2 tumor, I think radiation is the wisest choice. Grade 3 tumors are uncommon, but again, radiation is pretty standard, and often they end up finding their way into the medical oncologist's office for chemotherapy. This is the Simpson grade that you mentioned. Okay, what is this? Okay, all right. Yeah, let's say they present with visual loss. What do you want to do? What'd you say? Yeah, bitemporal immunosity.
We offer them surgery, transfemoral approach, and resecting tumor.
Okay, I know I'm trying to
Before that, we have to do a pituitary profile.
Yeah, right. Okay, I know I'm trying to rush things, and so maybe you're forgetting that, but forgetting to do this. Yeah. So, what's the one hormone you have to check for? My American colleagues will cringe and they'll say, one hormone? What do you mean one hormone? You got to check for all the hormones. Prolactin, right? So, again, at Tenwick Hospital, most of my patients can't afford a full pituitary panel, and I don't know what it's like necessarily in Nairobi or Eldoret. But if there's one hormone I'm going to check, it's going to be prolactin. Because I don't want to get caught with my pants down and operate with a prolactinoma, right, that could have been treated medically. Okay? So, you want to always check for prolactin, okay? And you mentioned the whole panel, and we're not going to go into how to treat Cushing's or acromegaly, all that kind of stuff. Now you mentioned they got visual loss. You're going to do a nasal resection. What do you want to monitor for after surgery? Did I not go the right way? I'm totally ruining this slideshow.
So together with the cortisol levels, TSH.
So post-op, what are you gonna? What's one of the main concerns you want to monitor for? Sure, right. So you're going to monitor urine output, right? And you want to get on your nurses about that. What if the patient presented with acute onset of headache and they've got bilateral ophthalmoparesis? What do you think? Do they have an aneurysm? Yeah, right, okay. So how are you going to manage that typically? Or what concerns might you have with someone that goes in that has apoplexy?
Due to insufficiency?
Yeah, right, okay. So you want to make sure you check cortisol levels right, and of course the whole panel. But you certainly want to think about replacing cortisol. Okay, what is this? 8-year-old presents with ataxia. Okay, pilocytic astrocytoma. It's this cystic structure, non-enhancing with an enhancing mural nodule, right? In that age population, probably the most common thing. So what do you want to do for that? Not these two. They've said enough. I saw a few hands over here.
Sam, you don't get your drive back unless you answer some questions. Why don't you go up here and see what the rest of the residents say?
Sam, they're throwing you under the bus, my man.
It's all on that microphone.
Okay, I think that sounds all right. Okay, so what's your goal of surgery going to be? Are you going to try to resect everything? Meaning, are you going to go after the cyst wall? Do you just want to resect this? Do you just want to stick a needle and drain this? What's your goal of surgery?
I think to avoid recurrence. Okay, I think I would resect all of it.
Okay. All right. I'm glad you're going to be careful. What part do you want to resect? That's all right. Yeah, that's fine. So, given this does not enhance, I would recommend not going and chasing the cystic part of this, just like you said. But if you can remove the cystic neural or the enhancing neural nodule, what's the prognosis for this kid? Pretty good, right? Are you going to radiate if you get a gross total resection post-op? I'm seeing heads shaking, right? So usually you won't radiate. So for a pilocytic astrocytoma, the goal is a maximum safe resection. Typically, you should be able to take the neural nodule out because they're usually in the cerebellar hemisphere, and then you're not going to radiate post-op. Everybody still with me?
Yes.
All right. This one.
That's medulloblasoma.
Okay. That would be my first thought. I know it's a crummy picture again. I'm sorry. Why do you say medulloblastoma?
May I ask the age of the patient?
Young. Yeah, I don't know, 10. That's certainly one factor to consider. Yeah.
Location still also.
Yeah. Okay, maybe I'll hold that question for the next case that I'll show you. Yeah, typically, so what's a common thing that you can confuse this with, or that often look the same? An ependymoma, sure. And I've got an example of that coming up. I gave it away, but typically, the medulloblastomas, they arise from the superior medullary velum, or the roof of the fourth ventricle, and they displace the brainstem anteriorly. Often the ependymomas will arise, or they do arise, from the floor of the fourth ventricle, and they're pushed the cerebellum backwards, and they extend out the foramen Luschka and down through foramen Magendie, and we'll look at some of that. But sure, honestly, you can't know until you take it out, right? So, Khalif, what do you want to do for this kid?
It's again offered in surgery, but the prognosis is also not very good. So offer them surgery in the sense of to relieve the symptoms and prolong life, but eventually it will recover. It might recover.
So,
Yeah,
good question, right? So that's something you always want to do for these patients is ideally you get a craniospinal imaging to rule out drop nets. Let's say there's no drop nets and you do surgery. Let's say you get a pretty good surgical resection. Maybe you've got a little nodule left, but it's a near total resection. What are you going to do? Are you going to send this patient home and say, come and see me in a year, or are you going to refer them somewhere? What do they need?
Refer to radio-oncology.
Okay.
And chemotherapy.
Yeah, most people would do both, radiation and chemotherapy. If they're, and in fact, what specifically about radiation in this tumor do you consider?
Age 3S.
Okay, yes, if they're less than age 3, you typically would proceed with just chemotherapy to delay the effects of radiation. But are you just going to radiate the posterior fossa? Right. You get, for these patients, they get craniospinal radiation, even if there's not evidence of drop nets on the MRI, and then they get a boost to the surgical bed, and most of the time they'll get CCNU chemotherapy too. Okay? So maximum resection followed by craniospinal radiation and chemotherapy. We already talked about this one. This is a good example of an ependymoma. So you see how it's more pushing the cerebellum back than it is the brainstem forward. It's extending down to the foramen magendi, out the foramen luschka. Those are some things that may clue you in that this is an ependymoma. What are you going to do for this? You're going to take it out, right? Okay, then what are you going to do? Are they getting craniospinal radiation? Let's say there's no evidence of drop nets. Okay, this is the same kind of scenario. You want to work them up the same. No drop nets. Do they get craniospinal? Lydia's shaking her head. I think you're right. Yeah, craniospinal is typically not done with ependymomas. What's that? They're normally low grade, although they typically have a worse prognosis than the medulloblastomas actually, because they're so prone to local recurrence. And there are so many different subtypes of medulloblastoma, of course, many of whom do have quite poor prognostic factors, but the ependymomas, while low grade, man, they can be a disaster to take care of because they can recur. Okay, I think this is the last one. What is this? And this leads into Dr. Anoop's lecture. It's a MET, okay? Yeah, that's certainly high on your differential, okay? So what do you want to do? Let's say this is a solitary MET. Okay, they've got a chest, something in the lung.
Let it down first.
Okay?
For the surgeon, if it's solitary.
Okay, all right. What's the surgeon going to do?
Well, hopefully he will take notes. If solitary MET, if the disease is well controlled systemically, the patient doesn't have too many comorbid conditions, and if it is technically feasible, possible, so not elephant region, then I would much rather have it resected than go for stereotactic radiosurgery or something.
Okay, so for a solitary metastasis that's surgically resectable, you should take it out. And most folks post-operatively, even with a gross total resection, would radiate the surgical bed with stereotactic radiosurgery. And again, recognizing we don't have that around here. What if, so we said a solitary lesion, what if you have a couple lesions, 2 or 3?
Size of the lesion.
One is symptomatic.
Size.
I don't know, 4 centimeters.
Location?
Frontal lobe.
Can you make it 3 centimeters? Well, if it's 2 to 4 lesions, and they're all within 3 centimeters, then it's stereotactic radiation.
Well, but she is, so yeah, it's a 4 centimeter frontal lobe tumor that's symptomatic. A lot of edema, the patient, I don't know, they're hemiphoretic.
So we did all that and they send them for whole
Then
brain.
you fight it out with the neurosurgeons and the radiation.
So you're going to take out the symptomatic one and then send them for radiation. If they're all 2 or 3 sub-centimeter or less than 3 centimeters, sure, you can consider direct radiation, right? And then typically if you have 3 or more lesions, folks are going to send them for either whole brain or there's publications of doing SRS for 10 or more tumors, I think. But in general, this is a reasonable algorithm. I think that's it, or where I'll stop anyways. Again, this was a very broad overview. There's a lot of nuances to this. But any questions about it? All right, thanks.